my name is Lauren Heathcote. I previously did a PhD in experimental psychology at the University of Oxford, which is where I met Rebecca. And I studied how our cognition, particularly how we pay attention to the body and how we interpret symptoms and sensations within the body, how that relates to pain experiences in young people. And I partly studied that in relation to young healthy people as well as children with chronic pain. So I did my PhD in that, and then I just finished a postdoc where I've been for the last 5 years here at Stanford Medical School in the Department of Anesthesiology, Perioperative and Pain Medicine, where I've still been studying the role of the brain and psychology, particularly sort of cognition as well as affect, so our emotions and our mood, how those influence. Myra. Good, nice to meet you. All right, so question number 2. So you asked, given your professional experience as a specialist in pain treatment, what's the relationship between the patient's cognitive process and his response to clinical treatment? So I should say from the start that I'm not a specialist in pain treatment. So I don't treat patients myself. I'm not a clinical psychologist. Like Rebecca, I'm an experimental psychologist. So I do research on the experience of pain, and I do a little bit of research on potential sort of intervention or treatment approaches, but I don't actually deliver the treatment myself, so that's just one caveat to keep in mind. But what is the relationship with the patient's cognitive processes and their response to clinical treatment? That's a big question. That's a very big question. I think my research has focused on a slightly different but probably related question, which is how does the individual's cognition or their cognitive processes, how does that relate to their experience of pain or other symptoms more broadly? And then that probably can tell us something about how it might impact their response to treatment, as well as what kinds of treatments might be helpful and effective. So we know that pain and really any physical symptoms that we feel, so fatigue, tiredness or itch, for example, these are all outputs of the brain. So all of these things come from our brain, and really they're just signals from the brain that are designed to protect us from potential harm. So pain is a signal that's produced by the brain that's designed to protect us from tissue damage. Itch, on the other hand, is a signal that's produced by the brain that's designed to... So in response to question number 4, what are the physiological and cognitive levels of pain recognized today by medicine? What are its main forms of treatment? So I don't know if I'm completely answering your question. There's probably a few parts to your question, but I think one way in which the field of medicine is recognized that our cognition is relevant for our pain is that the sort of gold standard non-pharmacological treatment for chronic pain is cognitive behavioral therapy. So it's therapy that we apply to and was originally developed for treating mental health conditions like anxiety and depression and things like that. And we have the best evidence that actually cognitive behavioral therapy is a helpful treatment for at least adults with chronic pain. There are other kinds of psychological therapies that involve like cognitive components like acceptance and commitment therapy, exposure-based treatments that we're starting to study now, and we don't yet have strong evidence whether they work or not, but we have good evidence that cognitive behavioral therapy works. And so I'd say that's a relatively well-recognized form of treatment for chronic pain. Challenging the cognitions, the beliefs that people have around their pain. For example, the idea that pain means that my body is damaged, and pain means that... Question number 5. So today, who are the recognized professionals of the interdisciplinary team in the pain treatment process who are part of the patient's rehabilitation? Yeah, it's a good question. I think that the treatment of pain differs quite a lot all over the world. And again, I'd be interested to hear your experiences of pain treatment in Brazil. I think it's generally agreed that the best thing that we have is, as you say, an interdisciplinary approach. And so that's multiple different medical professionals working together, right? So it's not just multidisciplinary where there's lots of professionals, but they're all kind of working separately. It's interdisciplinary, lots of professionals working together. So question number 6, what's the biggest challenge that I've experienced, and how do I deal with this clinical challenge for treatment? So yeah, I think this one's, again, a tricky one because I don't treat patients myself, but I can certainly speak a little to the sort of the research side and what I've seen through other clinical colleagues. Again, I think you'd probably be better suited to answer this question yourself with your experience. But I think one big clinical challenge we face is really moving away from this like biomedical understanding of pain, that pain is directly caused by tissue damage and is a reflection of something wrong in the body, tissue damage or nerve damage, for example, and moving towards a more biopsychosocial understanding of pain, which is that pain is an output of the brain, that it's designed to protect us. And really that any credible evidence the brain picks up to suggest that we need protection will impact our experience of pain. So one of those things certainly is tissue damage itself. So we have nociceptors and nerve endings within our body that pick up changes in pressure and changes in mechanical changes, and they tell us that there's damage in our bodies. And of course, that information is really important, probably the most important thing in explaining pain, certainly at least at an acute level when we experience acute pain. If I was to have a little paper cut, I'd experience a certain amount of pain. And if I was to have my arm cut off, I'd probably experience a lot of pain. And it's, that's undeniable, that tissue damage and that kind of information that's sent from the nerves in our bodies up to our brain is important, feeds into our experience of pain. But there are that's the sort of bio side of the biopsychosocial model, but there are other psychological and social factors that also influence our experience of pain. So I talked about how pain is about the perceived need to protect the body. And so, for example, if you have some sort of physical sensation that's picked up by the receptors in your skin and in your areas of your body, sent to the